Okay, thank you everyone, and welcome to section 6, incident classification number 2. So this is an add-on to the previous session, and basically is dealing with more challenging cases when it comes to incident classification. So my name is Brian Leshevsky. I'm a radiation therapist at the ODAT Cancer Center, and I will be presenting today. So what we're going to cover in today's session is a more detailed look at incident analysis, as well as a few case studies to see how your classification aligns with some of our experts in the use of NSER-RT. So you have a few accompanying case studies, which we encourage you to print off before completing today's session, as well as 2 copies of the NSER-RT incident data collection form for today's session. So when it comes to incident classification, the national system classifies incidents as one of 3 types. So there's an actual incident. So these are any incidents that reach a patient. A near miss, which is an incident that was detected before it reaches the patient, and a programmatic hazard. So these are hazards that do not involve a patient, but which have the potential to impact the patient if they're not corrected. So when it comes to actual incidents, those incidents that reach a patient, they may be associated with acute harm, acute medical harm, and that's harm that is evident immediately, some type of injury to the patient, or it can be delayed harm that manifests months or years after the event. And that is kind of coupled with that dosimetric metric that we use to inform us of what's the possibility of something happening down the road, decreased tumor control, or possibility of a secondary malignancy, things like that. So with respect to incidents that do not reach a patient, our near misses and our programmatic hazards, they have the potential to cause harm or are process issues requiring adjustments to prevent potential future adverse outcomes. So we're going to go through a few examples to see if we kind of can get a grasp on what is an incident, what is a near miss, and what is a programmatic hazard. So the first of which is during commissioning, a software error was identified, resulting in a reproducible error in a dose calculation. So how would you classify that incident? An actual incident, a near miss, a programmatic hazard, or you're just not sure? So in this instance, I would call this a programmatic hazard. And the reason for that is there's not a patient attached to this at this point. So there's some type of issue with respect to the technology or the hardware, which can be corrected, but there's not a patient involved yet. So it's not a near miss per se. It's something that can be corrected, but if you didn't do it, down the road, something adverse could happen. Second example, following the delivery of the coplanar beams, during gantry rotation with a couch kick, it was identified that the beam geometry would result in a collision. Ultimately, the plan was undeliverable. So how would you classify this incident? An actual incident, a near miss, programmatic hazard, or you're not sure? So in this instance, it would be a near miss. And that's because it was identified that the plan was not able to be delivered. There wasn't any harm to the patient. They didn't receive the incorrect plan. They didn't receive the wrong dose, something like that. It was just identified that prior to the delivery that the beam was not deliverable. So the next example, a planner completes their plan and sends it off to the next step in the process, the physics check. During this check, the physicist identifies an issue with the planner's documentation. So how would you classify this incident? An actual incident, a near miss, a programmatic hazard, or you're not sure? So this is where it gets kind of tricky. So you may think that this is a near miss because something down the stream caught an error upstream. However, the physics check is the actual next step in the process. And the purpose of that physics check is to check things from that planner directly upstream. So that's just showing that your QA program is working. A near miss would be if the documentation from the planner made it all the way up to the treatment floor and somebody doing an initial chart check caught that potential error. And it had missed the number of checks in between. So basically, a near miss is identifying some type of issue in your process that's not working. For example, if the physics check had not caught it, that near miss would be identifying that something in your physics check isn't working. We're humans, we're going to make mistakes, and the physics check is there to make sure that any of those mistakes don't get any further downstream. So in this instance, it doesn't fall in a near miss category. It's actually just your quality assurance step is working. Our next example, Ms. Jones is treated for a lesion at T4, is being treated for a lesion at T4. However, her plan is used to treat Ms. Smith for the same site and setup for one fraction. So how do you classify this incident for Ms. Jones? Is it actual, near miss, programmatic hazard, or are you not sure? So for the case of Ms. Jones, again, I'm going to let you choose not sure. So for Ms. Jones, her plan was being used to treat Ms. Smith. So she hasn't actually had any dosimetric harm or any kind of issues with respect to her treatment, save for the fact that there'd have to be some type of additional treatment fraction added in maybe the planning program to treat her for that fraction that was used for Mrs. Jones. So there's not really an incident per se for Ms. Jones. So for Ms. Jones, treated for the lesion at T4, and her plan was used to treat Ms. Smith, how would you classify that for Ms. Smith? Actual, near miss, programmatic hazard, or not sure? So in this instance, for Ms. Smith, that would be the actual incident. And the reason why I kind of highlighted this case is for within the national system, if you kind of had an incident involving two individuals or two patients with this kind of transposition of events, those two instances can be filed within the system as one incident affecting multiple patients. And that way you've got this singular story describing the event, but that it's tied to a number of patients. So now we're going to move on to problem type, which has been identified as a source of confusion within the incident classification system. And it can kind of be linked to a misunderstanding of how to classify incidents. And often we find in the classification system that other is the more predominantly used option, when there may actually be choices that are already existing in the system that might be more appropriate. So we're going to go through a few examples, give you an opportunity to try to classify them, and then discuss what would be the kind of gold standard classification and why. So the first of which is during breast peer review, it was identified that the incorrect side was planned for the patient due to documentation from the attending radiation oncologist. It resulted in a replan and a delay of 1 week for the patient. How would you classify this incident? I certainly hope not as other. Would it be wrong side, laterality, radiation therapy scheduling error, wrong anatomical site, excluding laterality. Give you a few more seconds to think on this one. So wrong side laterality would be the most appropriate problem type for this. So how does it differ from wrong anatomical site excluding laterality? Simply by the fact that D excludes laterality. So we wanted to kind of tease out those laterality issues. However, the patient did have that delay of 1 week because of the replan. So why wouldn't we choose radiation therapy scheduling error versus the wrong side laterality? And that kind of comes to some kind of classification theory or kind of a thought process. So when describing a problem type, it's best to characterize the incident by looking at the underlying issue. So exactly what are you trying to solve? What are you trying to fix in the program? So even though it resulted in a delay in treatment, you're not going to try to fix the delay in treatment in this case. What you want to focus is why are you accidentally focusing on the wrong side of the patient? What can we do to mitigate that wrong side problem type? So that is why the problem type is best characterized as the wrong side. So if you're kind of thinking, going to a root cause analysis, distilling it down, looking at the root cause being the wrong side was treated, laterality would be your problem type. And then working from a root cause analysis point of view, there's some other issues that may arise from it, the patient being delayed 1 week. And maybe we do come up with some solutions to deal with that. But hopefully by dealing with the laterality issue, all of those subsequent problems would be solved as well. So yeah, using that kind of root cause analysis concept and theory that was discussed in the earlier lectures, you kind of help drill down to what exactly is your problem type. Next example. So we have a 65-year-old patient diagnosed with prostate metastases to T4, T6, T10 to T12, and L3 to S1. So the plan is to deliver 2000 centigrade and 5 fractions to each site. The patient was planned correctly for each site. The first 2 treatment sites were completed correctly. Upon treating the LS spine, it was noted that there were no fields available for treatment. So how would you classify this incident? Treatment not delivered, personnel, hardware, software failure, systematic hardware software problem, radiation therapy scheduling error, or other. So the gold standard kind of for this one was chosen as being radiation therapy scheduling error. So it was kind of tricky to kind of tease down which one of these to choose. But the reason why I chose this as an example is to illustrate the importance of using the minimum data set for its definitions. So if we look at kind of the definition of the various items, radiation therapy scheduling or error is the incorrect coordination of one or more treatment tasks resulting in treatment delay of fractionation schedule not being followed, excluding scheduling errors related to combined modality care. So because there was some type of incorrect coordination of one of the treatment tasks, the patient was unable to have their appropriate care delivered. A systematic hardware software is something innate in the technology itself failing. So that one wouldn't necessarily be the most appropriate, and so that's kind of why we chose the other one. So when describing the problem type, again, if we can keep looking back to those causes, and maybe maybe the hardware or software problem could be a contributing factor, but in this instance, we want to kind of look at the coordination of care, or not the coordination of care, but the coordination of the tasks that resulted in those fields not being available. So our next example, during commissioning, a beam characterization error went undetected. A planned dosimetry check using a phantom for the first patient scheduled to the unit was completed. During this check, a reproducible error in dose measurement was identified. 24 patients scheduled to start the week were delayed as the program had no capacity for the patient load. So how would you classify this incident? Treatment plan acceptable but not physically deliverable, systematic hardware software problem, treatment not delivered, personnel hardware software failure, untimely access to medical care or radiotherapy, or other. So I'll give you a few seconds to kind of go through this, and hopefully you have your MDS now and you can kind of have a deeper dive into your decision making there. So the items that we kind of chose is two problem types actually. So systematic hardware software problem, as well as untimely access to medical care or radiotherapy. So I'll explain how this works. So the first of which is systematic hardware software, which includes a malfunction in either hardware or software that affects accurate delivery of treatment plan or results in patient injury. This includes, but is not limited to, hardware software malfunctions, equipment calibration errors leading to dose volume deviations affecting multiple patients. So that kind of covers that commissioning issue that we have. So that would be almost the first incident that we have. So we've nailed down our problem type for that issue. But there's also another kind of underlying issue within this program. It's the fact that there was 24 patients scheduled to start that week, and they had to be delayed because the program had no capacity for that treatment load. So there's that issue that's starting to arise of untimely access to medical care or radiotherapy because that program didn't have the capacity to meet those issues, or that issue, and kind of plan for those that potential problem. So you could, in theory, put in a second incident with respect to that, because the program should have some type of measure in place or some type of consideration in place to be able to deal with capacity. And perhaps it just might be something to have in the back of the mind to recognize that this is something that needs to be solved. So it's kind of an instance where there's almost two incidents layered within itself for classification. So another problem type example. So the patient is being treated to the T-spine. On fraction 5 of a 2000 centigrain 5 fraction prescription, the patient was treated using the setup instructions and one treatment beam of another patient. So the incorrect treatment beam, a posterior anterior lung field, irradiated an uninvolved area, the lower T-spine and abdomen. There was no overlap between the incorrect field and the prescribed beams. The attending physician approved the continuation of the correct beams following patient disclosure. The prescribed volume received the intended prescription dose, but there was a large uninvolved volume inferior to the prescribed volume that received an unintended dose of approximately 250 centigray. Give you a few more seconds just to read through that in case I went a little too quickly. Okay, going forward. So let's try a root cause analysis on that. As you probably know from your previous lectures in root cause analysis. This is a very, very rudimentary, non-representative, and poorly developed root cause analysis tree diagram, but we'll just use it for illustrative purposes only. So we have an incorrect patient treated. Could have been patient photo ID missing, patient was in a lot of pain, staff were unfamiliar with the patient, didn't do the birthday check. There was similarities between the patient, had confusion, unit was significantly delayed, and so on and so forth. So how would we classify this incident? An actual incident, near miss, programmatic hazard, not sure. So yes, this is an actual incident. Patient did receive dose to the wrong area. So what measure of acute harm would we assign to this incident? No harm, mild, moderate, severe, death, not sure. So the patient did receive some dose. So we'll call it no harm. The patient didn't, there wasn't a lot of detail in that description, but it wasn't the largest dose that the patient received to the area. So we'll assume that there was no acute harm in that instance. So what is the measure of dosimetric impact that you'd assign to this? None, minor, moderate, severe, not sure. So I have minor here. To be honest, not sure is very acceptable. It's very hard to say what the dose is. It could actually be severe. We don't know what the distribution looks like. We don't know what the dose to that inferior proportion should have been. It would really need to be evaluated by physics to understand what the dosimetric impact is. The reason why I put minor is just to make sure that people understand that it's not none. So often we think, oh, it doesn't matter what the dose is, it's minimal. Minimal does not equal none. If the patient received any dose, that means it's minor or above. So even though it's something that we consider negligible, it's not none. If there's some type of dosimetric impact, then it is minor or above. What measure of latent harm would you assign to this incident? Is there latent harm? Yes or no, or not sure, do not know. For this one, I put not sure, do not know, because I'm not a radiation oncologist, but there was also not a lot of information in that. But that's also just, again, identifying that there needs to be that assessment, not only of the dosimetric harm to the patient, where it's located, what organ it's over, but also that kind of analysis, that entire analysis of the impact, so that we can be properly informed of our assessment of the latent harm. So when it comes to problem type, how would you classify this incident? Wrong anatomical site, wrong patient, wrong target or OAR contours, or other. So for this patient, when we look back at the case, so the incorrect beam from a previous patient was actually used to treat this patient. The incorrect treatment beam, a PA lung field from another patient, was used to treat that patient. So in this case, it would be wrong patient was kind of the involvement of an incorrect patient information or an incorrect patient at any step in the treatment process was the causation. We'd be tempted to use wrong target OAR contours because it was kind of the wrong area that was treated or the wrong volume. But the reason it was the wrong volume is because it was the wrong patient's information that was used. So now we're just going to have a quick little chat about contributing factors and classification issues when it comes to contributing factors. So these are kind of the list of the contributing factors that exist within the National System for Incident Reporting. So I just kind of went through with respect to this case and highlighted some potential contributing factors when we think back to that rudimentary root cause analysis. There could be some documentation issues, equipment issues, maybe external factors, maybe lacking policies and procedures, some patient family issues, patient might have been in pain, things like that, staff behavior. Kind of what I wanted to highlight with respect to this is, again, the importance of doing those root cause analyses. That's where you kind of get your richness and understanding of what's going on. A lot of times you might look at an incident from face value and you could actually have assumptions of what happens, where there actually could be a lot of contributing factors that are hidden. And by doing these root cause analyses and more in-depth analysis of your incidents, you can get this richer information. And that richer information in turn is more important when reporting to the system, because it gives other individuals who want to learn from your incident a greater understanding of things. And they might say, oh, I never even thought of XYZ as might be contributing to that incident, which was very similar to something that happened in my program, and therefore kind of helps perpetuate that learning. And then as well with the ameliorating actions. So ameliorating actions are those steps taken to better compensate to better compensate the harm due to a specific incident. They can apply to the patient. Ameliorating actions can apply to the patient, either the clinical management of an injury, apologizing, and then to the organization as well, staff debriefing, clinical change, claims management. And then the actions taken to reduce risk concentrate on those steps taken to prevent that incident from occurring and improve system resilience. So these are the lists of the elements within the incident reporting system as well. So we've got our organization related and patient related. And I think it's just important because often we might gloss over these and say, oh, we didn't do anything. And if you haven't done anything and can't think of anything to fill out in this, I think that's maybe an opportunity to say, well, why haven't we done anything? Certainly, I would hope that we've disclosed to the patient about an incident, regardless of whatever incident happened. And perhaps it's now trying to be more mindful when we're putting things in place after an incident happened, of considering these items and what we can actually do, regardless of what type of incident we had, to help improve our systems. So now we come to our case studies, the first of which is a high-risk prostate patient. So the description is Mr. Jones. He's a 65-year-old patient diagnosed with high-risk prostate cancer, T4, Gleason score 9, PSA 25. He's scheduled for simulation December 28, 2017 for VMAT treatment. All patients ideally should have a fullish bladder and an empty rectum at the time of CT simulation. In addition, if the rectal diameter is greater than 4 centimeters, patients are asked to empty their stool/gas and be rescanned. If after one attempt the problem is still present, the attending physician will be contacted about further instructions. Options at that time include rescanning on another day or attempt to deflate the rectum with a rectal tube or fleet enema. Mr. Jones was Mr. Jones was informed about this protocol at the time of consult, but stated that he forgot by the time of simulation. However, he felt ready for the scan. So he did not meet the bladder rectum constraints. He was rescanned and still did not meet the simulation parameters for rectal volumes. A third scan was completed following the administration of a rectal tube by the attending physician. Mr. Jones completed planning and proceeded to treatment as per the third planning scan. So at this time, we'll give you the opportunity to pause the session. You can get your NCRT incident data collection form out and take the opportunity to go through and classify the incident. And when you're ready, you can click to resume the session. So welcome back. So I hope you had fun going through and trying to classify that incident. So we're just going to go through the various elements and ask you how you classified and see if you kind of align with the gold standard. So how would you classify this incident? An actual incident, a near miss, programmatic hazard, or you're not sure? So I apologize to anybody who had a lot of issue going through with this one and trying to classify it, or those of you who did go through and classified it, because it was kind of a trick question. The answer is not sure. And by not sure, I mean the proper policies were followed in this case. So even though Mr. Jones went through a number of additional imaging steps involved in his treatment, they followed the policies and procedures according to the program as was specified by the program. So it's not actually considered an incident. He was imaged accordingly. He was provided the education. He felt full. They had all the information and they acted on it accordingly. Even though he did have additional imaging, the decision-making processes were all appropriate. So in this instance, it wouldn't necessarily be an incident. It's just following the policies as they're stated. So I apologize if folk went through and racked their brains over it, but it was just a learning process to help you understand that although we may have patients undergo a number of what we perceive as inconveniences or something like that, that doesn't necessarily mean that it's an incident. It's just the process by which, it's just the process of our practice. So moving on in Mr. Jones's journey, so it's the excuse me, it's the program's policy that patients with an implanted cardiac pacemaker shall be treated as to minimize the risk of the device failure. So for CT simulated, the ICP should be included in the CT image if it's close to the treatment volume. So when Mr. Jones's volume was contoured, it was identified that his ICP met the criteria for consideration of the program's ICP policy. As per the policy, all patients should be provided with a referral to arrhythmia services to evaluate the device before and after the radiation treatment course. Additional testing of the device may be required throughout the treatment course. If the device dose limit is being exceeded, or if the patient has an intermediate clinical risk as evaluated by arrhythmia services, weekly testing is recommended. If high energy photons are used, regardless of the device location, or if the patient has a clinical risk as evaluated by arrhythmia services, daily testing is recommended. Recommendations from arrhythmia services stated that Mr. Jones should have daily magnet placement with heart monitoring. These recommendations were not translated into the chart. Daily magnet placement and weekly arrhythmia clinic visits were not followed. 10 of the 23 fractions were delivered without magnet placement, resulting in negligible dose to the ICP and no acute harm. As well, Mr. Jones missed 2 arrhythmia service clinic visits. Arrhythmia clinic was notified, and the patient will be seen at arrhythmia services after the treatment. After the investigation, it was noted that the therapist performing the pre-treatment chart check did not realize patients receiving prostate treatment could potentially be eligible for ICP consideration. It did not consider this when transferring documented recommendations from arrhythmia services. In addition, these recommendations are found with another source, not in the electronic medical record. So again, we invite you to pause the session. You can get your NSER-RT incident data collection form, go through and classify the incident, and resume the session when you're ready. This one's not a trick question. So welcome back. So we're just going to go through and kind of take up the coursework there. So in this instance, it's an actual incident. So Mr. Jones did receive dose to that wasn't necessarily accounted for. There was no acute medical harm that was highlighted in the case. Minor dosimetric impact, which again was kind of noted, and also given the location of the pacemaker. There's no latent harm because it was just his regular plan, and everything was kind of considered just with respect to his VMAT treatment. And then the problem type that we chose was inadequate coordination of care. And the reason for that is the definition for inadequate coordination of combined modality care is inadequate coordination of radiotherapy with surgery or chemotherapy, and including not limited to improper patient handoff or improper or insufficient information exchange between medical and/or allied health disciplines and scheduling errors. So included in that is those kind of important handoffs that we have not only within our programs, but also many of the other allied health professions that we work with. So a lot of these incidents are kind of based in reality and loosely based in reality. And in my experience, I've come across some of these that are, we've had to rack our brain kind of finding which problem type this best fits into. And yeah, the one like this was, it was difficult to hammer down exactly where it fit, but yes, inadequate coordination of care was kind of the best category for it, because that is what we want to improve. We want to figure out a better way that we can identify the fact that a prostate patient could potentially be considered for arrhythmia services in this case. And there's a lot of other instances where maybe there's some type of referral or something that needs to be done that we need to improve. So that's the kind of reasoning behind choosing inadequate coordination of care. So yeah, just asking what classification step did you have the most difficulty with? Just give you a few seconds to kind of ponder that on yourself, what you think actually might be where you're finding your difficulties, and you can kind of take that back. I would assume it's problem type, contributing factors, etc. And for that, I would highly recommend the MDS at your side at all times when you're doing incident, filing your incidents. The definitions really help clarify changing your decision from other to an actual problem type. So I just wanted to leave you with some final thoughts, not only with respect to these two cases, but just with respect to the overall reporting process in general. So the first of which, so did you consider these 1 or 2 incidents? Second, did you consider this a local process variation, not of national concern? And do you feel that a root cause analysis is necessary to classify this incident properly? So when it comes to considering this 1 or 2 incidents, so let's say hypothetically Mr. Jones' first event was in fact an incident. Maybe they scanned him improperly for some reason. So just like Ms. Jones, I believe it was, having her treatment field on Ms. Smith, or that instance with the potential for the patients that had 24 patients that were delayed with respect to the commissioning errors. There's some instances where incidents can be considered discrete, even though they kind of involve the same patient, and instances where incidents can be kind of lumped together, even though they involve multiple patients. And this is an example where maybe these could be, if that first incident was an actual incident, could be entered into the system as 2 discrete learning events. So that's a consideration to take back when you're entering incidents of what exactly is the learning lesson. Is it something that we could actually maybe split up, or is it something that we can lump together for folk who are probing in the system, trying to find a learning lesson? And yeah, independent reports may be of benefit to learners. So next, do you consider this a local process variation? Maybe, but you might have solutions or a better defined process than another program who maybe have a similar pacemaker related issue. And it may open that learning opportunity. NSER has that communication tool. And maybe I have a pacemaker issue going on in my program, and I really don't have my head wrapped around on any type of process. And I'm looking in the system and I find an incident related to pacemaker, and I start reading yours. And I say, wow, that's kind of similar to what I'm trying to solve here. And I start to get a lot more information from yours. And yes, we may have slightly different processes, but then I start to get an idea of stuff that I might be able to do in my program. And then I even have the option of potentially contacting you, and maybe we can actually start a dialogue. And now we've got a great learning opportunity established between the two of us. And that's what's fantastic about having things in the incident learning system, is being able to have that sharing of information and learning. Whereas if I'm kind of isolated in a program somewhere, that I'm not reinventing the wheel, I'm able to learn from other people. And then finally, do you feel that a root cause analysis was necessary to properly classify the incident? You notice that I didn't take up your contributing factors and your ameliorated actions, et cetera, with respect to this exercise. And that's because there is a lot of information missing from that case. There's kind of a lot of guesswork. And that's, again, just to kind of hammer down that the importance of doing a proper investigation into an incident, so that you can get that understanding and get that clear picture of what exactly went on, so that you can, again, when you enter it into the system, give that most detailed description of what happened, not just simply bolus error, but a highly descriptive understanding to those who want to learn from your incident, so that we can maximize the learning that comes from it. So yeah, the more information that you can gain to describe the incident, the richer the narrative you will have, and the better characterized incident that you'll have. And often it will help you choose your problem type easier, and definitely your contributing factors and so on, and ultimately help you decide what actions you want to make going forward, which I think is kind of one of the most important messages that's kind of coming out of this entire course as well, is the importance of it's not just an incident reporting system, that we're looking at an incident learning system. You can't just have an incident, report it, throw it on a shelf and leave it there. It's the active learning from it that makes incident reporting and an incident learning system useful. And that's why I will leave you with today's lesson. Thank you very much.